All right, guys, we're back. Endocrinology, and yeah, we're going to the dear and near of my heart, pancreatic emergencies. Yes, there are several versions of that. And being a insulin-dependent diabetic, I can tell you that, yeah, this one's kind of near and dear to my heart. So let's get to it. Let's talk about it. Diabetes mellitus. We talked about diabetes insipidus. Has to do with the pituitary in the brain. Diabetes mellitus down here. Then again from the pancreas. It's your blood glucose levels. It enables your body to store energy as glycogen, protein, fat, etc. All right. So you have to have that. A couple of things. Anabolism is the building process of the cell. Catabolism is the breakdown process. Anabolism actively uses energy. Catabolism actively produces energy. We talked about that in the citric acid cycle, okay? So in order for the anabolic pathways to proceed, you got to have insulin as a stimulatory effect, okay? It allows that to happen. It brings in the nutrients. It's kind of like the key holder. It allows that big molecule to get inside of the cell so that it actually can start using the glucose to make energy, okay? Now, sometimes the body cannot use glucose as the primary energy source, and when that happens, again, in diabetes, often when there's insufficient insulin, guys, you actually go into a catabolistic state. You actually go into that acidotic state because remember back with the citric acid cycle, when you didn't use oxygen to create carbohydrate, to create energy, the same thing happens with a diabetic patient, okay? So it produces acid along with the limited and small amount of energy that you'll get through anaerobic metabolism, okay? So the body slowly switches from glucose to fat as the primary energy source. And this also creates acid, okay? So that's why we kind of worry about those things. And actually, when you start breaking down the fat, it turns into ketones, okay? And then, so actually, you see some of these diets, the caveman diet, or they go into ketosis, and they actually do it on purpose. And actually, to lose weight, you have to actually burn fat, and that produces a certain amount of ketones, okay? Now, when we're talking diabetics, though, it's usually a lot of ketones, putting them into ketosis, that it causes a diabetic coma, okay? So I think it's kind of a misnomer when they call it that, because actually what it is it's actually the catabolic state of breaking down the fat, okay? But it produces a tremendous amount of acid, throws the blood pH all off, okay? So again, blood glucose levels lower than 80 reflects hypoglycemia. Now, you said, well, wait a minute, Scott, we usually don't treat it till it's below 60. And that's a true statement. Again, to understand the definition of hypoglycemia is below 80. Emergently, we usually don't treat it till it's below 60, okay? Now, that also is very relative, all right? So if you've got somebody who's normally used to a 150, 160 blood sugar, and they go down to 80, I can assure you they're going to be doing the whole sweating thing, having a sympathetic reaction. They're going to be feeling weak. They're going to be feeling dizzy because their normal state is 150, okay? So again, that's a guideline, guys. It's a guideline, all right? Sugars greater than 140 is considered hyperglycemia. The days that I have a sugar below 140, I'm usually extremely happy. So again, so remember that your kidneys are involved with this, because the way that your body gets rid of excess sugar in the system is it dumps it out through the kidneys. By the way, all that glucose going through your kidneys, not a good thing. Okay, so it actually it's not reabsorbed by part of urine; it's excreted from the body. So you guys got to understand that's why, especially with your patients on kidney dialysis, boy, that makes it a nightmare to treat. Because remember, these guys can't get rid of their excess sugar the way that most people do. And it also leads to some of the problems that we see for a diabetic emergency. All right, so glucose loss in urine can lead to dehydration. I can't stress that one enough. I can tell you that when I first got diabetes, guys, I was literally probably peeing 30 times a day. Literally, I would drink the nearly 30 to 40 glasses of water trying to stay hydrated. Okay, and I couldn't drink it fast enough before I was peeing it out. Okay. And glycosuria is the presence of the glucose in the urine, and it creates sweet urine. Matter of fact, a little story here. Back in the old days, that's how the doctor could tell that you were a diabetic. He'd do a little taste test of your urine to see if it was sweet. Yeah, nasty, right? So, so type 1 is, again, its actual beta cells have been destroyed. It produces very little or no insulin at all. The common term is juvenile onset or insulin-dependent diabetes mellitus, IDDM, and that's probably the more correct medical term that we should probably use. Again, type 1 is less than type 2, but it is more serious because, again, they cannot actually produce insulin, or there's so little insulin being produced. Accounts for most diabetic deaths, by the way, is type 1 diabetics. And again, it's not only the sugar issues, but the damage that it does to the bloodstream and to the organs, because the sugar continues to, and usually because it's high and fluctuate. Dr. Oz used to always say, think of glucose as kind of like shards of glass in your vessels. And unfortunately, that's actually a pretty decent analogy of it. An untreated type 1 diabetic's blood glucose levels can rise where they cannot take up circulating sugar, and again, it can cause problems. So again, these guys usually have if they don't take insulin, can have sugars 300 to 500. When I did my glucose tolerance test, which is this test where you drink the orange soda to see if you're a diabetic, I got up to 1250. Okay, so it's very easy to get it up that high. So again, so some big key signs that you get with this, by the way, drinking a lot, peeing a lot, eating a lot, feeling weak, a lot of weight loss. Guys, I went from 330 pounds to 170 pounds in 3 months, okay? I was having cramps everywhere, horrible thing. And it may produce frank diabetic ketoacidosis. I'm really surprised that they didn't put me in the hospital when I was first diagnosed, because I can tell you right now, I guarantee you, if they'd have taken my blood pH, it was probably down around 7, okay? So type 2 diabetes is non-insulin dependent diabetics. Your body produces it, or it's resistant to the insulin that you make, okay? So understand the major ways that they treat that is, again, weight loss, good diet, exercise, and then they may supplement and cause your pancreas to create more insulin using medication. Okay, but it's usually a pill form of medication. But that, instead of actually giving insulin, it stimulates your body to make more insulin. Okay, it's very common to have this. Untreated type 2s, they present with a lower level of hyperglycemia and few major signs and symptoms of metabolic disruption. Again, the initial therapy, usually for them is, again, diet change, good exercise, and they might give them the oral agents. And however, you can go to the insulin actually being needed as a supplement. At that point, we call them insulin-dependent diabetics, though. So let's talk about diabetes here.
Insulin is a critical chemical produced by the body to assist the body's cells in utilizing glucose. When sugar intake and insulin production are balanced, the body can use glucose as an energy source. Decreased insulin production causes diabetes mellitus, or sugar diabetes. The most common diabetic emergency is hypoglycemia, or low blood sugar. Possible causes: patient taking too much insulin, not eating, over-exercising, or vomiting. Symptoms include abnormal behavior, sweaty skin, faintness, and depression. Untreated hypoglycemia can lead to unconsciousness or permanent brain damage. Diabetics test the blood's glucose level at least once a day to determine precisely how much insulin to take to keep blood glucose levels near normal, which reduces complications including heart disease, blindness, and kidney failure. Glucose meters require placing a drop of blood on the strip. Some EMS agencies carry blood glucose meters. Others do not allow EMTBs to use them.
We all know that that's not true, because obviously that is a staple in treatment right now. Real quick, before we go any farther, there's one more way that diabetics can actually check themselves. So this is my blood glucose right here, right now. I wear a small sensor on my stomach, and let me show this guy right here. So that's my port site, and down here, so this is actually a glucose sensor, okay? So again, every 5 minutes, that takes my blood glucose. So I know what my sugar is. Guys, these are becoming much more prevalent, and they should be. As a matter of fact, to be blunt, every diabetic should have those. Even the type 2s, guys, should actually have that, okay? They truly should. Because, again, if we can maintain control of the diabetes, and technically, I guess I got a 142 right now. So I guess technically, I guess I am a little bit hyperglycemic. Believe me when I say I'm at 142, and I'm very happy about that. Now, diabetic ketoacidosis, okay? This is a life-threatening complication. Again, we're not producing, there's not enough insulin in there. And coupled with increased glucagon activity, it starts to burn down. The body cannot take in the glucose, the loss of glucose in the water. Again, it causes osmotic diuresis and basically produces a severe dehydration of that, okay? As the body switches to that fat metabolism, your ketones rise. And again, increased urine production, dry, warm skin, excessive hunger and thirst. And that's the difference between them. As it develops, you're going to start developing, in order to maintain your acid-base balance, you're going to start breathing faster and deeper, okay? That it helps expel carbon dioxide. And by the way, you're going to get this nasty, fruity smell on the breath. I may or may not actually intentionally go into diabetic ketoacidosis on you guys so that you guys can actually, truth be known, there's a simpler way to do it. Take a piece of juicy fruit, chew it up, and guess what? It smells just like that. Okay. For the diabetic, it smells, it's horrible. Matter of fact, it's kind of a clue that, yuck. Okay. And then over time, again, the mental function declines. And by the way, that time frame is somewhere around 24 to 36 hours. It can go on in actually weeks before they can actually start having mental status changes. Okay. But usually it's 24 to 48 hours, somewhere in there, that they're going to have an issue. Okay. Again, the assessment of the DKA patient is just like every other one. Look for the medical alert bracelets. Look for insulin in the fridge. Again, and this is the one that you do your glucose, your finger stick, and again, make sure that if it's above 500 or reads high. Okay, so it kind of depends on the meter. Some after 400 say high, some after 600, but usually over. We can just let's assume that if it says high, it's definitely above 400, and it is it's horrible actually. So what you need to do for this patient, ABCs, and then fluid hydration. Okay, and these patients are more than likely going to be dehydrated. Give them fluid. Give them fluid. Give them more fluid. Give them fluid, isotonic crystalloids, okay? We want to do that. And by the way, be ready, because they're going to pee, okay? Because the second they get fluid in there, the kidneys are going to go, hey, I got to get rid of this glucose, okay? Now, HHNK, hyperglycemic states, usually with a type 2 diabetic, guys, okay? It's a serious complication. Hyperglycemia it causes dehydration. Basically, it's diabetic ketoacidosis without the ketones, okay? Because the body has gotten used to that state, okay? And again, type 2 diabetics usually have this. Again, they're not the mortality rate, by the way, from getting going into acidosis from this state, actually the mortality is around 40 to 70%. It's extremely slow in onset. The good news is, guys, it's the same. Again, the only real difference as far as the diagnosis, especially for test purposes, DKA is usually your type 1 diabetic. HHNK is usually your type 2 diabetic. Okay, that's really the only difference. You treat them the same way. Lots of fluids. Again, as soon as you can, get them to the hospital. They need to get the pH level. They need to start correcting the acidosis. Okay. Again, and if you can get a pH on these guys, like if you're at a nursing home or or if you're actually at a facility where they've got the ability to test it, going their pH is actually a really good thing. All right. So hypoglycemia. Again, now this is where you got a low blood sugar. All right. They've either exercised too much, took too much insulin, or they didn't eat enough. Okay. And by the way, all three are bad. And the problem is that you can start killing brain cells by doing that, okay? So hypoglycemia is something we need to correct and correct quickly. These are usually the pale, cool, sweaty because it is a form of shock. You need glucose just as much as you need oxygen, okay? So again, the diaphoresis, tachycardia, again, get the blood sugar. It develops usually very quickly. HHNK, DKA, slow in onset. Low blood sugar, quick in onset. And you guys have been in class when I've had a couple drops, okay? And I can tell you, woo, yeah, boy, it doesn't feel good, okay? If they're conscious, able to swallow something with sugar in it, sugared sodas, orange juice, glucose paste, glucose tablets. Again, most every diabetic I know, again, here I'm going to show my example here. Yep, guess what I carry? There you go, blood glucose tablets, right? They go with me everywhere, okay? Again, it's usually good if you got a mild case of hypoglycemia, it helps bring the sugar up. Patients unconscious, we need to get an IV started. We need to give them, some sort of dextrose solution. 250 milliliters of D10, 50 to 100 milliliters of D50, whatever. Again, sugar, and we are okay getting it into them, all right? Again, remember, the reason we like to use D10, D25 in a greater amount is because they're less caustic on the vein. D50, very caustic on the vein, okay? Does a lot of damage, and you really need to be giving it in a running IV slow. Guys, when I give D50, I start 1,000 bag, I run it wide open. As I'm giving the dextrose, I will stop, let some flow in, stop, let some flow in. And the reason is that way you don't do as much damage to the vein. If truth be known, if I got a bag of D10, that's really the kind of the way my preferred method of treatment is to hang a bag of D10 and let it flow with piggybacked to a normal saline line. So in other words, I plug that into the normal saline that's flowing, and then I administer the D10 and then do it that way. All right. Hyperthyroidism. Again, we're going to stop there actually because that's a whole different topic. Again, so when I treat the diabetic patient, again, I want to know what their sugar is. If it's high, if I can get their pH value, that'd be wonderful. If not, it's not a big deal. But again, I'm probably going to be thinking lots of fluids and get them to the ER where they can get an insulin glucose drip. Okay. Yeah, by the way, when we give insulin via IV, we give it with glucose. Despite the fact that their sugar is 500, you still have to have some glucose to metabolize in there. If you have a low blood sugar, I want to give them in a flowing line that I know for a fact is very patent and is not blowing up. There should be no question about the patency of my IV. Give it slow. If you're using D50, give that poor vein a break, okay? But we got to get that blood sugar level up, okay? We really do have to get the blood sugar level up or you're going to start killing cells, okay? So again, the more that you can dilute it actually is a better thing. All right, let's get a little bit of an insight on the diabetes and diabetic emergencies, okay? A lot of other emergencies that we have are related to the complications of diabetes, by the way. Cardiovascular effects, neurological effects. And very unfortunately, again, it's a very prevalent disease in our society. But by the way, very manageable, very controllable. And that's the thing I got to stress, okay? So again, educate your patients on this. It makes such a big difference. All right, that's it for the diabetes, and I'll see you guys on the next one.